Welcome friends. Today we are here to discuss about the hypertension, the condition hypertension and the drugs used in hypertension. So, in this class we are going to discuss about the introduction of hypertension, that means what are the types of hypertension, what is hypertension, and the classification and mechanism of action of hypertensive drugs, anti-hypertensive drugs. So, what is a hypertension? Hypertension is a condition, it is a physiological condition where there is an increase in the arterial blood pressure above normal. So, what is the normal blood pressure we have seen, that is 120/80. 120 is the systolic blood pressure, whereas 80 is the diastolic blood pressure, and it measures in the unit mmHg. So, if there is an increase from the normal blood pressure, then it will be called as hypertension, and if there is the low blood pressure than the normal BP, normal suggested the range of BP, then it will be called as hypotension. And today we are here to discuss about the hypertension, that is the higher BP than the normal BP range. So, an individual is hypertensive when the blood pressure is more than 140 to 90 mmHg, and hypotension, it is defined as the physiological state or physiological condition when there is a decrease in the arterial blood pressure, that is if the BP is lower than 90/60, that is systolic blood pressure is 90 and diastolic blood pressure is 60. If a patient is suffering from this condition, then it will be called as hypotension. Now, there are two types of hypertensions, that means the higher BP. We are talking about higher BP here, we are not talking about the lower BP, we are talking about the higher BP. So, there are two types of higher BP, that is higher or hypertension. It can be called as higher BP, it can be called as hypertension, anything. So, there are two types of it, primary and secondary. Primary hypertension, the causes is not exactly known. So, there are 90% chances, 90% cases when there is a no known cause for hypertension. It is also called as essential or idiopathic hypertension because there is no known reason for that. And the second hypertension is called as secondary hypertension, that is when the causes are known. That means it is happens because of some associated problem, associated health problem, then this type of hypertension happens for a stipulated time or started later on, and with some associated conditions it has started. So, there are some conditions like eclampsia of pregnancy. You have heard that a pregnant woman is hypertensive. Before pregnancy she did not have any such condition, such type of condition, but with the pregnancy she developed hypertension. So, this will be considered as secondary hypertension, and certain more reasons are there, that is renal artery diseases or pheochromocytoma. That means there are two types of hypertension, first is primary hypertension and the secondary hypertension. So, primary hypertension, the causes are not known, 90% time the causes are not known, that can be hereditary, that can be any reason because of not exactly with any associated with any health issue. But in the secondary hypertension, particularly this type of hypertension is associated with some sort of health issues. So, primary hypertension, we can see 90% of the cases are primary hypertension, whereas rest of the 10% cases are secondary hypertension. So, if we need to check the blood pressure, how can we do that? So, it is a simple formula, blood pressure can be checked by the formula, that is CO into SVR. What is CO and what is SVR here? CO is the cardiac output and SVR is the systemic vascular resistance. That means, if we need to know the blood pressure, we need to multiply these two things, cardiac output and systemic vascular resistance. Then comes the classification of the drugs. In our syllabus, they do not ask about the classification. They have given the drug names. So, we are going to discuss the drugs accordingly to their classification. So, the first class in this antihypertensive drugs are diuretics. In diuretics, there are several agents which are used as antihypertensive, that is thiazide, high ceiling diuretics, potassium sparing diuretic, ACE inhibitors and angiotensin blockers, also called as AT1 receptors. We have discussed in our previous class the diuretics. So, we have seen there that the diuretics we have used diuretics in certain edema conditions and hypertension. So, these were the drugs which we have studied in details. So, the first we can summarize it here also. So, diuretics, the first class, that is thiazide. In thiazide there are 3 drugs: hydrochlorothiazide, chlorthalidone and indapamide. So, these drugs are specially meant for used in hypertension. Second comes as high ceiling, that is high ceiling diuretics. In this class the furosemide is there. Then third is potassium sparing diuretics. Then in this class spironolactone and amiloride is there. Then comes ACE inhibitors. In ACE inhibitors there are several drugs: captopril, enalapril, lisinopril, peridopril, perindopril, ramipril and fosinopril. Maximum times we use these agents in hypertension along with the other drugs of hypertension. And the last class here is angiotensin blockers, that is losartan, candesartan, irbesartan, valsartan and telmisartans. Then these are the diuretics. Then comes the next class, that is calcium channel blockers. In calcium channel blockers the drugs are verapamil, diltiazem, nifedipine, felodipine, amlodipine, nitrendipine and lacidipine. Next is beta adrenergic blockers. This class, beta adrenergic blockers, it has propranolol, metoprolol and atenolol. Then comes beta plus alpha adrenergic blockers. In this class labetalol and carvedilol. Next comes alpha adrenergic blockers. Here is prazosin, terazosin, doxazocin, phentolamine and phenoxybenzamine. Next class is central sympatholytics class. In this class drugs are clonidine and methyl dopa. And the last class for antihypertensive drugs is vasodilators, that is hydralazine, minoxidil and diazoxide. And these are the agents, these are the antihypertensive agents. I have made the agents with the structure because we need to study the structures a lot. So, these are the agents which are given in our syllabus. So, we have to study the structures of these agents also. Earlier we have studied the classification here without the structure. So, after studying the classification we should know the structures of the agents of our interest. So, these are the agents, these are the hypertensive agents, drugs with the structures. So, the lisinopril, enalapril, captopril, timolol and benazepril. Then comes quinapril, clonidine, guanethidine, methyl dopa and guanifacine. Sorry for the written mistake. Then comes guanabens, sodium nitroprusside, dioxazide, hydralazine, minoxidil and reserpine. So, these are the drugs which we studied for the antihypertensive agents. So, how these drugs work? that is the drugs which interacting with the renin angiotensin systems. How do they work? If you see the simple class, if you the flow chart, if you see the simple flow chart, what happens here, what is the condition, why the hypertension happens and where these drugs are to be incorporated is explained very clearly. So, we can see there is an agent, that is angiotensinogen. Angiotensinogen converts into angiotensin 1, which ultimately converts into angiotensin 2, and this angiotensin 2 then attach with the angiotensin receptors, angiotensin 1 and angiotensin 2, these receptors. After applying, after reacting with these, the condition changes and there is a increased pressure of blood happens. Now, we need to control the blood pressure here in this hypertension condition. This is the normal condition which is generally happening with everybody, with every individual. But the patients who are having hypertension, that needs to be corrected here only. So, there are certain agents, the anti-hypertensive agents need to be work to stop the happening of the normal which is happening here, we need to stop that. So, the angiotensinogen when converts into angiotensin, the renin works here, that means there is ACE dependent pathway is this, and renin works here to convert the angiotensinogen into angiotensin 1. Now, here if we stop this pathway, if we stop the conversion of angiotensinogen into angiotensin 1, our some sort of problems will be solved. What are DRIs here? DRIs are direct renin inhibitors. That means we need to inhibit the renin system here. Then in the second part, the conversion of angiotensin 1 into angiotensin 2, what happens here? Here the bradykinin which is converting into inactive fragments, here the ACE is working. ACE is working in here, that means conversion of angiotensin 1 into angiotensin 2. ACE is working here. ACE is converting the angiotensin into angiotensin 2. It is called as angiotensin converting enzyme. ACE is called as angiotensin converting enzyme. So, we need to stop here also. So, what we can use here is, we can use is ACEI, that is angiotensin converting enzyme inhibitors. We need to act those agents here to stop the conversion of angiotensin 1 into angiotensin 2, and ultimately if this will not happening, so here there is no production or very less production of angiotensin 2. So, the ultimately the increased blood pressure will be slowly diminished. Then after that, where we can also use our agents, our antihypertensive agents are in the third phase, that is the conversion of angiotensin, or you can see the addition of your angiotensin 2 to the receptors, that is angiotensin 1 and angiotensin 2 receptor. What we can do is, here we can use our ARB. What is our ARB? That is angiotensin type 1 receptor blockers. We can use these so that the angiotensin 2 should not get connected, should not get attacked with should not get joined with AT1. So, we need to add, we need to use ARB here. So, in the flow chart, which is the this is the normal flow chart which is normally happening, but here we need to stop for we need to stop the flow chart in some places, so that the blood pressure should not be increased further and the increased blood pressure should be slower down a bit. So, in the first phase, angiotensinogen will be converted into angiotensin 1, we need to stop here. So, with the use of DRIs we can stop this or we can diminish the activity somewhat. Then angiotensin 1 will convert into angiotensin 2, we can again stop here by using ACEIs, and ultimately at the third phase when angiotensin 2 will get attached with AT1, here we can use the ARBs for the final stop attaching the angiotensin 2 to AT1. So, like what? Like this we can use our antihypertensive agents. So, comes the ACE inhibitors. Let us discuss the ACE inhibitors. The angiotensin converting enzymes inhibitors are recommended as first line treatment for hypertension in patients with a variety of compelling indication, which includes coronary diseases, risk of history of diabetes, stroke, heart failure, myocardial infarction or chronic kidney diseases. So, in these conditions, in so many these conditions, angiotensin converting enzyme inhibitors can be used. Then they are also, ACE is also responsible for the breakdown of bradykinin, a peptide that increases the production of nitric oxide and prostacyclin by the blood vessels. So, both nitric acid and prostacyclin are potent vasodilators. So, we need vasodilators here for the removal of the pressure in the blood vessels. So, ACE inhibitors are very helpful in decreasing the blood pressure, in decreasing the hypertension of the patient. Then ACE inhibitors decreases the angiotensin 2 and increase bradykinin levels. That means what happens here? Vasodilation happens. So, vasodilation is a result of decreased vasoconstriction from diminished level of angiotensin 2 and enhanced vasodilation, that is from increased bradykinin. And by reducing circulating angiotensin 2 levels, ACE inhibitors also decrease the secretion of aldosterone, which resulting in decreased sodium and water retention. This is again a very important point to be noted, that sodium and water retention, it happens because of the property. This is again a condition in hypertensive patients, the retention of sodium and water in their body. So, it needs to be reduced, the retention of water and sodium should be reduced. So, for here we are using ACE inhibitors along with some diuretics. Diuretics here will help us to stop the reabsorption of sodium ions and excreting natriuresis, that was to do the natriuresis from our body. So, by reducing circulating angiotensin 2 levels, ACE inhibitors also decreases the secretion of aldosterone, resulting in decreased sodium and water retention. Then ACE inhibitors reduced both cardiac preload and afterload, thereby decreasing cardiac work. That means what happens here? What happens in the hypertensive condition? That means how the blood pressure is increased. That means the blood vessels will be constrict more, because by constricting the blood vessel, the pressure of the blood will increase. It is a very simple experiment we can do in our home, that we can see how the blood pressure increases. The normal rubber pipe we have at our home for watering the plants in our house, or by using those rubber pipes we can transport water from one place to another place. If we see the by constricting the mouth, the opening of that rubber tubing, rubber pipe through which the water is flowing, you can see the water coming out of the mouth of that pipe will be go farther than it was going previously if you opened the mouth wide of the rubber pipe. So, like that in our body, what happens here, if the blood vessel will constrict more, the blood pressure will increase because there is very less space to travel the blood. So, if the constriction happens, the blood will travel to a faster pressure, faster speed because of the pressure. So, ACE inhibitors reduces the cardiac preload and afterload, thereby decreasing the cardiac work. Then comes mechanism of action of ACE inhibitors. They inhibit ACE, which is involved in the conversion of angiotensin 1 into angiotensin 2. That means what happens here? There is a vasoconstriction happens here. ACE helps in the vasoconstriction. So, if we stop the ACE by using ACE inhibitors, so there will be no conversion of angiotensin 1 into angiotensin 2, which will help us in doing the vasodilation. So, the drugs captopril, lisinopril, enalapril, benzapril, hydrochloride, quinapril hydrochloride, they helps as vasodilation, helps in the vasodilation. So, where we can use, in which conditions we can use these ACE inhibitors? They are the first choice in the treatment of hypertension. They can used in the left ventricular failure, they can used in the diabetic neuropathy, they can be used in myocardial infarction. So, the conditions where we can use the ACE inhibitors are these. Then comes the SAR of ACE inhibitors. This is the general structure, or you can see the general assembly of ACE inhibitors. That means this whole thing. If you see the whole thing, you see the structure, that means an R group is attached, is bind to the groups that bind to zinc ion. Then this is, the whole thing is attached with the rest of the structure, that is a CH group, which is attached with an R. Then it is attached with a CO group, carbonyl group, and N with the ring. This is the whole assembly of the ACE inhibitors. If you see any structure of ACE inhibitor, you will find the same things in there. Now, what happens if we change certain things in the structure to increase the activity? First of all, very first thing, methyl group resembles side chain of alanine. That means, if we add the methyl group, this methyl group resembles side chain of the alanine. Okay. So, here if we do any modifications in this part other than alanine, that means we can use a small methyl group here, but more than that we cannot add. If we add some bulky group here, what will happen? It will ultimately reduces its activity. Then comes second is enhances the potency, the ring, the nitrogen with the ring, it enhances the potency of the compound. That means the presence of ring with the nitrogen is very important for its activity. Next is N-butylamine in dicarboxylate containing compounds orally active. That means, if we add here N-butylamine in some drugs, the oral potency, the oral activity increases. That means, you can take the drugs orally and they will be quite potent. Then essential for the stabilization, that means the zinc ion here is very essential for the establishment of the whole drug. And then the sulfhydryl group, again I am telling you the sulfhydryl group is very important for the activity, because in the diuretics we have also studied the sulfhydryl group in ASM inhibitors, there was also ACE inhibitors. So, in the there also we have seen the sulfhydryl group. Here again I am telling you the sulfhydryl group is very important, is the most important part of any ACE inhibitor. Then comes a drug, that is Reserpine. This is the drug which comes from natural origin, is used in hypertension. It is other than ACE inhibitors we can use in hypertension, that is, it is a root extract of naturally occurring plant Rauwolfia serpentina, earlier, in the very early days, it was the first line therapy for reducing the blood pressure. Nowadays, it is less commonly used because we have many advanced medicines here which are used here. So, Reserpine can be given nowadays also, but with in combination with certain drugs for hypertension. So, these compounds act by depleting catecholamines including norepinephrine, dopamine and serotonin from central and peripheral synapses. This mechanism of action has allowed Reserpine to be used as an anti-hypertensive and anti-psychotic medicine also. Along with the anti-hypertension, it can used as anti-psychotic medication also. This is the I am again repeating, this is the only medicine which is used naturally and used in as anti-hypertensive agents. So, Reserpine is effective in reducing systolic blood pressure roughly to the same degree as other first line anti-hypertensive drugs. It is adrenergic uptake inhibitor. Reserpine can be prescribed alone or in combination with the vasodilator or thiazide diuretics such as Reserpine hydrochloride. So, it can be used in combination with a vasodilator or a thiazide diuretic such as Reserpine hydrochlorothiazide. This is the mechanism of action of Reserpine. We have already discussed the general mechanism of hypertension. What happens? Hypertension, we do the initial treatment here, then comes the blood pressure, decrease in blood pressure, which ultimately divided into two parts, that is increased sympathetic outflow and increased renin released. Here, after this increased sympathetic blood flow, what happens? When the sympathetic outflow increases, it causes tachycardia and ultimately again blood pressure increases. So, what we can do is, here before this, after conversion, after doing the decreased blood pressure, what we can do is, we can use some beta blockers and Reserpine. We use beta blockers and Reserpine here, so that tachycardia should not happen and ultimately blood pressure should not increase. So, in the early symptoms of hypertension, very early symptoms of hypertension, Reserpine is a very good agent to treat the hypertension. And in the second case, what happens? In the initial stages, then decreased blood pressure, after what happens? Increased renin release, and which ultimately is treated with the diuretics and ACE inhibitors. So, Reserpine can be used in the early treatment of hypertension. As soon as the hypertension detects, the patient are advised to go for some beta blockers and Reserpines, so that the initial cycle of increased hypertension should not happens. So, these are the references which I have used for making the slides, that are some chemistry books, that is Wilson and Giswold, Organic Medicinal Chemistry, the Synthesis of Essential Drugs, then Foy's Principle of Medicinal Chemistry, these are and Principle of Medicinal Chemistry by S.S. Kadam, K.R. Mahadik and K.D. Bhotra. I have used these for medicinal chemistry purposes, one more book for medicinal chemistry, and then finally for using the pharmacology by KDT. Hope the session was helpful. Thank you so much.